Yeah, يعطيكم العافية. Last lecture we talked about treatment planning in orthodontics. We discussed the examination in lectures before, but then we mentioned that we have a database of information. We have to analyze this information to get up with a problem list, and we learned last time how to do problem list. Then we decide what are our aims of treatment. Then we decide the options for treatment, and then we go ahead with the informed consent and provide the definitive treatment plan. However, when we do the treatment plan, there is some basic principles of this treatment plan. And these principles are explained nicely in your textbook, Laura Mitchell. So I'm assuming that all of you has to read this textbook. So the basic principles of treatment planning. The first one is the oral health. Now, we never ever start orthodontic treatment for a patient with a poor oral hygiene. The reason for that, because orthodontic treatment will make it even worse because they harbor the plaque and they cause more damage to the teeth if the patient does not have a good oral hygiene at the start. So whenever we have a patient with poor oral hygiene, we don't provide him with treatment. We will wait until the oral hygiene gets better. Now, when we do treatment planning, usually we start with the planning of the lower arch. However, having said what I'm saying right now, this is slightly changing in the world. I will teach you both ways. Now, this is the lower arch kind of treatment that was 20 years ago or 50 years ago. Now, in the last couple of years, we start by planning the upper arch, and I'm going to explain all of them. So regarding the lower arch treatment, why do we prefer to start planning the treatment depending on the lower arch? Then, so basically, when you do treatment planning, you look at the lower arch first, and then you start looking at the upper arch. The first reason is the stability. So what do we mean by stability? Now, if you remember, Prophet has a theory, equilibrium theory. So basically, the lower incisors are stable in their position because they are in a balance between the force generated by the tongue and the force generated by the lips. So the lips are trying to push the lower incisors backward, while the tongue is trying to push them forward. And as a result, they are in this position where it's in balance. So basically, if I procline the lower incisors, I'm kind of invading the space of the lower lip. And what the lower lip will do, they will push the lower incisors back to where we started. And it's the same if we retract the lower incisors, then we're going to invade the tongue space and the tongue will push the lower incisors forward. So basically, the lower incisors, where they are, is the most stable position. And some studies said that the maximum I can move the lower incisors forward without causing unstable result is 2 millimeter only. But there are certain exceptions in which I can procline lower incisors and still get stable results. What are these situations? Thumb sucking. And the reason for that, because the thumb sucking will result in retroclination of the lower incisors. So basically, this is not the stable position of them because they are not in an equilibrium position here because we have an extrinsic force coming from the thumb. So whenever I move the thumb, then I can put the lower incisors, procline them to compensate for the retroclination that is taking place because of the thumb. So thumb sucking, we can procline lower incisors. Cases with the class 3, basically the lower incisors usually are ahead of the upper centrals. So we do extraction to treat these cases usually and retract the lower incisors until we achieve a positive overjet in situations similar to this. And by that, by retracting the lower incisors, we are changing their position, but they are stable because they are going to be under the control of the upper central incisors and they will never be proclined again. So these are the cases where we can procline. Class 2 division 2 cases, there is a theory that the lower incisors are completely covered by the upper central incisors. And by that, the forces from the lip never reach the lower incisors. In fact, they affect the upper incisors. And for this, we don't have a really equilibrium theory here because the upper incisors are kind of like a shield against the lower lip, and they are preventing them from the touching of the lower incisors. So whenever we procline the upper incisor and procline the lower incisor, we're going to get the stable results because of that. The more recent thing about the proclination of the lower incisors is aesthetic. Now, consider this patient to understand. Now, this patient has a class 2 skeleton, and if you look at the nasolabial angle for her, you can find that she has a really increased nasolabial angle. And if you could look at the mandible, you can see that the reason and the etiology for this class 2 skeleton is retrognatic mandible. So if I'm gonna treat this patient, the only way to treat her is by moving her jaw, her lower jaw, the mandible, forward to compensate for the class 2 skeletal. But if the patient doesn't want to go for surgery and she wants her teeth to be fixed when she has a huge overjet like this, the only way to fix her teeth without making her profile look worse is by moving the lower incisors forward. And in these cases, I will move the lower incisors forward, knowing that I'm doing that with unstable results. And the patient has to use what we call it a bonded retainer for the rest of her life because we can't get it stable results by proclining the lower incisors. However, we get a more acceptable aesthetic result. Because the other option for me to treat this big overjet is to extract 2 premolars in the upper and retract the upper incisors. With a patient with this nasolabial angle, she will look even worse if I do something like that. So her options will be to accept this increased overjet or to go for orthognathic surgery to move the lower jaw forward, which is the best option for her and will give her the best aesthetic results. However, not everybody is happy to go for orthognathic surgery. And if she insists on going on treatment, the only option I can provide here is by proclination of the lower incisors. And I'm going to move them more than 2 millimeters. And I'm invading the lower lip space. And I'm introducing an unstable results. So if I'm doing unstable tooth movement, then I have to retain this movement for life. And the patient has to understand this from the beginning. So the exceptions now to move the lower incisors forward, when we have a thumb sucking habit, or we will have a stable result, when we have a class 2 division 2, when we have a class 3 class 3 incisor relationship. In all these cases, we're going to have a stable results when we move the lower incisors. But the last one, which is aesthetic, we will not going to have a stable result, and the patient has to be retained for the rest of his life. This is what we treat here with a lot of elastics. She gets a positive overjet, we reduce the overjet, but still nothing improved her profile. This is another case to show you where we can sometimes procline the lower incisors as well. Just as an example, this patient has a 5 millimeter overjet, so we have to reduce this overjet by 3 millimeter. Why, if you do space analysis in her, in the upper arch, I did that for you. Space available minus space required, it is 6 millimeter. And she has an overjet of 5 millimeter. So in order to reduce this overjet into 2 millimeter, we need 3 millimeter of space in each side, which give it 6 millimeter in both sides. And already I need 6 millimeter. That means I need 12 millimeter of space to relieve crowding and to correct the overjet in the upper arch. But I can make this easier by reducing the overjet purely by proclination of the lower incisors, such in this case where we have the crowding of the lower arch is 4 millimeter, which means if I procline the lower incisors by 2 millimeter, that will reduce the overjet from 5 into 3. And then I need to reduce it in the upper arch only by 1 millimeter, which means I reduce the space demand in the upper arch by 4 millimeter by simply proclination of the lower incisors. To get this again, and that's why we start. This is another reason why we prefer to start treatment planning in the lower arch, because it's like building blocks. So I'm building the lower arch and then building the upper arch around it. So to make sure you understand this previous point again, now this patient has a 5 millimeter of overjet. To reduce it, we need to reduce it into 2 millimeter, which means I need 3 millimeter in each side, on the right and the left, which means we need 6 millimeter of space. Now, if I procline the lower incisors by 2 millimeter, this will reduce the overjet from 5 into 3. And now, when I do the treatment planning in the upper arch, I'm starting with a 3 millimeter overjet. I have to reduce it into 2 millimeter. So I need only 1 millimeter each side to reduce the overjet. So now I need only 2 millimeter in the upper arch. And this is going to make our life much easier to treat this patient. So whenever we plan, we start planning with the lower arch, then the upper arch, because we're building the upper arch around the lower arch. So now once we finish the lower arch, what about the upper arch? What are we going to do regarding the upper arch? I'm sorry. So in the upper arch, there's a couple of things that we have to consider. First of them are the midline, because the midline treatment can decide in which way we're going to move the teeth. So if you have a look here at this patient, you can notice that the upper midline is shifted to the right by about 4 millimeters. Because you can see this is the upper midline and this is the lower midline, and you can see that they are apart by about 3 to 4 millimeters. And examining the patient from extraordinary, it was obvious that the upper midline is shifted. The other thing, yeah, as you can see, the other thing that you need to consider is the canine angulation. So this canine here is distally angulated. So when you look at the canine that is distally angulated, you have to remember that at the end of the treatment, the canine should be slightly with mesial angulation. So basically, when I start the treatment for this canine, it's really hard to move this canine all the way backward if it's distally angulated. So if I decided to use a removable appliance for this patient, removable appliances are only capable of a tipping movement. So if I'm going to tip this canine distally, this is going to make it even worse. So I can't use a removable appliance in a patient with distally angulated canine. Plus, when the canine is distally angulated, it means that I have to move it back to be like this, which is slightly mesially angulated. And the canine has a big root, which means I have to move the root all the way back from mesial side to the distal side of the tooth. So that by that, I will have to reinforce my anchorage. Again, the canine is a very big tooth. The root is really big and really long. So if I decided to upright a distally angulated canine to be mesially angulated, it means that I have to move the root within the bone a long distance. And this is very anchorage demanding because I'm moving the root within the bone. The buccal segment relationship. You remember last time we talked about the buccal segment relationship, and we agreed that we always have to finish in a class 1 canine relationship. But the buccal segment depends on how we finish, how we treat our patients. If we're gonna go on a non-extraction treatment, then we have to finish in a class 1 molar relationship, as in this patient. To make it easy for you to understand it, whenever you go like sitting with the teeth, the only way to get a positive overjet of 2 millimeter canines in a class 1 with all the teeth present, the molars has to be in a class 1. There's no other way to do it. But if we do, like the patient here, extraction in the upper arch only, as you can see in the bottom photographs where we don't with the pre-treatment photograph, and the top one we have a post-treatment photograph, the patient extracted 2 units in the upper arch. Now she has a canine in a class 1, and the molars are full unit class 2. And this is how we finish when we do extraction in the upper arch only. But if we do extraction in the upper and lower arch, as you can see here, the patient in the bottom photograph, she lost 2 premolars in the upper and 2 premolars in the lower. And as a result, the canines are class 1 and the molars are in the class 1 too. So if we do extraction in the upper and lower arch, we have to finish in a class 1 molars. And if we do an extraction in the upper arch only, it's a class 2 again, but it's always have to finish in a class 1 canine. Canine is our guide for a treatment planning. This is kind of keystone when we think about the space required and the space needed. Because you have to think always that I have to put the canine in a class 1. And then you can calculate the amount of the space that you need. How are we going to do this? For example, look at this patient here. The canine here in this patient is a half unit class 2. Our target is to move the canine into a class 1, which means that the canine has to move this distance, which is half of the crown width of the lower canine, which is 7 millimeter. So half of the 7 millimeter is a 3.5 millimeter. So that means that if I do extraction in the upper arch, I need 3.5 millimeter of this space for the anterior crowding, because it's like a keystone. We move the canine until they are in a class 1, and then everything will be corrected. So now I need 3.5 millimeter of space on the right, on the left side, in this case, to be treated into class 1 and to correct the malocclusion. So this takes us to the next step of treatment planning, which is anchorage. Now I'm assuming that you had a complete lecture about reinforcing anchorage. Just to refresh your memory, it's a resistance for the unwanted tooth movement. Newton's third law of physics, each force has a reactionary force that is opposite in the direction and equal in the amount. So here, if I'm trying to retract the anterior segment posteriorly, the reactionary force will be that the posterior segment will move forward. Now, if I need most of the space, this is unfavorable tooth movement because simply I don't want the molars to move forward. It depends on the space condition. But if I don't want the molars to move forward, then we call this as unwanted tooth movement. So let's take this patient as example again. So you have the canine in a class half unit class 2. So that's mean, and that molars are half unit class 2 as well. So that means I need to extract 1 unit in the upper. This 1 unit will provide me with 7 millimeter of space. Now I need to move the canine in the upper arch until it's class 1 from half unit class 2. And this is about 3.5 millimeter of tooth movement, which means that I only need half the space of the extracted premolar. Then the tooth movement of the posterior teeth, they are not unwanted. I wanted them to move forward because you remember the final molar relationship in the upper arch when I do extraction only in the upper arch, it's a full unit class 2. So now I have a half unit class 2 molar. I want this molar to move forward. So I want this space to be closed by half of the space to be closed by the anterior teeth and half of it by the posterior teeth, which is fine. Then I don't have to reinforce my anchorage. This is how you think when you decide to reinforce your anchorage or not. On the other hand, when you see this patient, she has a full unit class 2 molar canine. And as a part of my treatment plan, I have to move my canine back into a class 1, which means I have to move it a full width of a canine, which is about 7 millimeters. I decided to take out one of the premolars. The mesodistal width of the premolars is 7 millimeters as well. So now I need all the space, I need all the space now of this extracted second premolar. So now I have to reinforce my anchorage. I can't allow these molars to move forward to take the space because I need all of it. I need all the 7 millimeters. Another way to think about it as well, you look at the molar relationship. We agreed that if we do extraction in the upper arch only, the final molar relationship will be full unit class 2. Now it's already full unit class 2, so I can't allow the molars to move forward any millimeter, any fraction of a millimeter. And that's why I have to reinforce my anchorage with maximum anchorage, maximum reinforced anchorage, which can be provided only by headgear or TADS. And this patient was treated with headgear. Retention. As I mentioned before, you're going to have a complete lecture about retention and relapse next year. But for this lecture, if we decided to treat some crowding like this, we need to retain this crowding with a bonded retainer. And if we decided to procline the lower incisors more than 2 millimeters, again, but also we have to retain the patient more than 2 millimeters. Now we finished kind of basic principles. Now we're gonna go just quickly see a couple of cases. How do we think when we do orthodontic treatment? So this patient here attended your clinic. If you can do a quick extraoral examination, you can see that she has a class 2 skeletal relationship. And the etiology of this class 2 skeletal is obviously a retrognathic mandible. She has a well vertical proportionate face, and she has a slight midline shift of the upper incisors to the left. Okay, if you look to her cephalometric values, you can see that the SNA is 82, which is normal. However, the SMB is reduced and the AMB is 8. So this patient has a class 2 skeletal due to retrographic mandible. If you look here, lower arch, we can see mild spacing in the lower arch with the lower incisors are slightly average, 96 with a normal value 92 plus minus 5, make it average. However, in the upper arch, we have all the teeth present. We have mild spacing as well, slight rotation of the upper right lateral, but we have procline upper incisors. If you look at the buccal segment relationship, you can see that we have a 9 millimeter of overjet and we have a 3/4 unit class 2 canine. So if you're going to write a quick problem list for this patient, she has a class 2 skeletal. She has an incompetent lips with lip trap. Sorry, I forgot to mention that in the previous slides. She has a class 2 division 1 incisor relationship. She has a 9 millimeter overjet. She has a class 2 molars. She has a class 2 canines. She has increased overbite. She has an upper midline shifted to the left by 3 millimeter, and she has a moderate upper arch and lower arch spacing, and the upper incisors are proclined. Now, these are the problem lists. Now, we need to decide which one of these problems are we going to treat and which one are we going to accept. Let's just start with the skeletal. Yeah, we're going to correct because we're going to use something we're going to see right now. Incompetent lips, here we're going to correct. Molar relationship and overbite, yes, we're going to correct. Midline. So basically, we're going to pretty much correct everything. So how we can do this? We have treatment options. Accept is not an option. Growth modification, camouflage, and orthodontic surgery. Accept is not an option. Growth modification is our option because simply the patient is growing and she has an increased overjet, and we are aiming to correct class 2 skeletal. However, by the way, this kind of correction of class 2 skeletal is kind of confusing because we know for a fact that functional appliance, they don't do orthopedic effect. They don't stimulate the growth of the mandible. All what they do is they kind of do to alveolar effect. So recently I started to like the terminology of trying to improve the class 2 skeletal rather than correct it, because simply we're not correcting class 2 skeletal. However, camouflage is not an option now. Orthodontic surgery is not an option because she's a young patient. And that's what's happened. She's fitted with functional appliance, and the functional appliance, as you can see, reduced the overjet. But this is now not enough because she still has spacing, and she needs to be treated with a second stage with fixed appliance. But look at the canines. When we started, they were quarter unit class 2 and the 3/4 unit class 2 on the right side. Now it's class 1. And on the left side, it's even half unit class 3. So the canine relationship hugely improved by using functional appliance. And this is kind of the hard part of treatment. Still has a midline shift, and then it's required the second stage of treatment. As we mentioned in the functional appliance treatment, most of the patient need functional appliance to use the overjet, and overbite, and then we need the fixed appliance treatment for them to finalize the treatment. And this is how she finished. As you can see, she's treated with a non-extraction in the upper and lower arch, so she finished in a class 1 canine and a class 1 molars. This is how we finished her treatment. A slightly improvement of the profile, but we did not definitely correct the class 2 skeletal. We just improved it. Look at this patient. We saw her before. She has a 5 millimeter of overjet. In the upper arch, she has a 6 millimeter of crowding. And in the lower arch, she has 4 millimeter of crowding. So we decided that we're going to procline in lower incisors to correct this overjet and to correct the midline. And you can see okay. For some reason it gets disconnected. Okay, and as you can see, we have a midline shift in the upper, and this is very important now, because if you can see, we have a midline shift, which means we need more space on the right side, on the left side, than we need it on the right side. And that's why we decided the extraction pattern to be slightly different. So again, now the treatment options either accept, growth modification, camouflage, and orthodontic surgery. Accept is not an option. Growth modification, we don't need it. She does not have that huge overjet. Camouflage is our option, not orthodontic surgery. And as you can see, we mentioned about the extraction decision. Now, because we have a midline shift on the upper to the right side, we decided to extract upper left 4 and upper right 5, because the midline is going to the right side and we need the midline to go to the left. But at the same time, on the right side, we need space to align the canine. And that's why we have a push coil here in which we will push. And as a result, the 4 will 5 will go back, creating a space for the canine. And at the same time, the whole dentition will go to the left side to the space of the extracted upper left 4 and correct the midline. In the lower arch, we don't need to do any extraction. The canine now has enough space, and that's how she finished in the class 1 molars. Class 2 canines, because we did the extraction with the midlines, are coincident. Another patient here, just quickly to provide you a different way of providing space. If you can see now, she has a coincident upper midline with the midline of the face. But if you look intraorally, she has a missing lateral incisor on the right side and a big shaped lateral on the left side. The space that we have it here is only 3.5 millimeter. So this space is not enough to place tooth for her. So if we want to place a tooth for her, we need 7 millimeter for a lateral incisor. So we need to enlarge the space of this missing lateral incisor from 3.5 into 7 millimeter of space. Now, in order to do this, we can't use a simply push coil to push the teeth because the midlines are correct. If I put a push coil in the space, the upper incisors will move to the left side, making the midline wrong. So the other option is to extract upper right 4 to create space. But this is kind of irony. I'm going to extract tooth to place an artificial tooth, which is kind of something that we don't like to do. And that's left us with the last option of space creation, which is simply distalization. So what we did is we fit this patient with mini screws, as you can see, the one with a composite on it, that's to reduce the irritation to the gingiva, and we tied it to the lower 4. And we placed a push coil between the 5 and the 6. Now the push coil is going to push teeth in both directions. It's going to move the 4 and 5 mesially, and it's going to move the 6 distally. But because the 4 and 5 are tied to the tab, which is anchored to the bone, the 6 only will move distally, while the 4 and 5 will not move easily. And as a result, we created a space for this patient, 7 millimeter, enough to enlarge and place an implant without jeopardizing the midline. Last case that we have is this young man. If you look at him, he has a class 2 skeletal, severe retrographic mandible. But the important part that his chief complaint was the mandible. It was not his teeth. His teeth was on the list of chief complaint, but the main one was a retrographic mandible. For that, we have to provide him with a treatment to correct the mandible. So our treatment options accept of the growth modification, camouflage, and orthodontic surgery. Accept is not an option because the patient is looking for treatment. Growth modification is an option if he was younger. Now, because he's an old man, not really old, but he passed the growth spurt, we don't need to provide him with the growth modification. Camouflage treatment is not an option as well because the patient is complaining about his profile. We are left with the last option, which is a growth orthodontic surgery. And as you can see, this is him before orthodontic surgery, and this is him after orthodontic surgery. And you can see the huge improvement in his profile. So basically, the only way to improve his profile this way is to go for orthodontic surgery. And this is him after 1 year. He grew a booty, and he looked much nicer. At least he kind of like stained his hair. And this is him after we finish orthodontic treatment. Thank you very much for your time. We're finished now with this lecture.
يعطيك العافية دكتور.
الله يعافيك، بس اعطيني اياه اعمل ستوب